The hospital in Bunia is not a large building. It sits in the capital of Ituri province, northeastern Democratic Republic of Congo, a city of mining dust, market noise, and roads that disappear into jungle. The nurses here are used to hard work. They are used to limited supplies. They are used to patients arriving in the last stages of things that should have been caught earlier. In early May 2026, something began moving through the wards. First one nurse, then another. Fever, vomiting, a weakness that came fast and hit hard. Samples were taken. The results came back negative for Ebola, so the staff kept working, kept touching patients, kept doing what nurses do, staying close, staying present, because that is what the job demands. The samples were wrong. By the time the Institut National de Recherche Biomédicale in Kinshasa ran a second round of tests, 8 out of 13 samples came back positive. The date was May 15, 2026. And the number of people already suspected of carrying this virus was not 5, not 20, not 50. It was 246. The virus had been moving for weeks, in silence, through a hospital, through a city, through the hands of the people trying to stop it. The word Ebola comes from a river. In 1976, a disease erupted near the Ebola River in what was then Zaire, now the Democratic Republic of Congo. Dr. Peter Piot, a young Belgian scientist, was among the researchers who flew in to investigate. What they found was unlike anything in the medical literature: a hemorrhagic fever, severe vomiting, organ failure, and in the worst cases, bleeding from the body's openings. It spread through direct contact with bodily fluids. It killed fast. It killed often. In that first outbreak, the case fatality rate reached 88%. They named it after the river. Since 1976, the DRC has recorded 17 outbreaks of Ebola. 17 times this virus has emerged from the forest, entered a human body, and begun to move. The 16th outbreak ended in December 2025, declared over after 64 cases and 45 deaths in Kasai province, a case fatality rate of 70%. The response teams packed up. The surveillance continued. The world moved on. 5 months later, Ituri was burning. But this outbreak is not like the others, and that distinction matters more than almost anyone is saying. The virus confirmed in Bunia in May 2026 is not the Zaire strain, the one the world knows, the one that caused the catastrophic 2014 West Africa epidemic that killed more than 11,000 people. The vaccines developed after 2014, the treatments rushed through clinical trials, the protocols built at enormous cost. They were built for Zaire Ebola virus. This is Bundibugyo virus, a different animal entirely. Bundibugyo was first identified in Uganda in 2007. It has caused only 2 previous outbreaks, one in Uganda, one in DRC in 2012, with death rates between 25 and 50%. It is rarer, it is less studied, and as of May 2026, according to the CDC, there is no approved vaccine for it. Treatment is supportive care only: fluids, oxygen, keeping the patient alive long enough for their immune system to fight. In a province with limited oxygen supplies and overwhelmed hospitals, supportive care is a fragile hope. The geography of this outbreak is what terrifies the people tracking it. Ituri province is not isolated. It is a region of miners, traders, and cross-border movement. The health zones of Mongwalu and Rwampara, where cases first clustered, sit in an area shaped by gold mining, where workers move constantly between DRC and Uganda. Bunia, the provincial capital, is a city of transit. By May 16, 2026, one day after the outbreak was officially confirmed, cases had already appeared in Kinshasa, the capital, a city of over 17 million people, more than 1,500 kilometers from Ituri. 2 confirmed cases were reported in Kampala, Uganda's capital, on the same day in 2 individuals who had traveled from DRC. Africa CDC noted with alarm that the 2 Ugandan cases appeared to have no connection to each other. The virus was not moving through a jungle, it was moving through airports. On May 17, 2026, the World Health Organization declared this outbreak a public health emergency of international concern, a PHEIC, the highest level of global health alarm available under international law. By May 18, the U.S. implemented enhanced travel screening and entry restrictions. By May 22, 744 suspected cases and 176 suspected deaths had been reported across Ituri, North Kivu, and now Sud Kivu province, a new province added to the list overnight. The numbers were growing every morning, and health experts were saying something deeply unsettling out loud. The true number of infections almost certainly exceeded the suspected cases by a significant margin, because this virus had been moving before anyone was counting. Here is where you need to pause and ask a question that is uncomfortable but necessary. Why did 246 people become suspected cases before the world was told? The answer is not one thing, it is several things tangled together, and they are not new problems. Ituri province has been affected by armed conflict and insecurity for years. Population displacement is constant. Healthcare infrastructure is stretched. Trust between communities and health authorities, in a region that has seen repeated outbreaks and repeated interventions, is fragile. Contact tracing requires people to cooperate with strangers arriving in protective suits, asking questions about who they touched and who they buried. In a place that has buried its dead in the shadow of 17 outbreaks, cooperation does not come automatically. This is the reversal that changes the entire story. The real problem was never the virus alone. Ebola is dangerous, genuinely, terrifyingly dangerous. But Ebola without Bundibugyo would still spread in a place where a nurse cannot afford to stay home when she feels unwell, where a hospital cannot isolate patients for lack of rooms, where a community mistrusts the very system that is supposed to save it, where a mining economy moves people across borders faster than any contact tracing operation can follow. The virus did not create these conditions, it simply moved through them. Ebola has always found the same address: poverty, conflict, broken systems, isolated communities with no margin for error. Every one of the DRC's 17 outbreaks has happened in this same landscape, not because the people there are careless, but because they have been left with the least protection against the thing that keeps coming back. What does this mean for the rest of the world? In 2014, a Liberian man named Thomas Eric Duncan traveled from Monrovia to Dallas, Texas. He was carrying Ebola. He did not know it. He was admitted to Texas Health Presbyterian Hospital, where staff were not prepared for what they were seeing. 2 nurses became infected. Duncan died. The United States had its first Ebola case on American soil, carried there not by malice, but by a man who simply got on a plane. The world in 2026 is more connected than 2014. The flights out of Kinshasa do not stop because WHO issues a declaration. The mining contractors fly home for leave. The families visit across borders. The movement that makes the modern economy function does not pause for a virus most people in transit have never heard of. Bundibugyo is not airborne. It does not spread through casual contact. The risk to any individual traveler remains low. CDC has said this clearly. But low individual risk and low collective risk are not the same number when a city of 17 million is already involved. The healthcare workers in Bunia knew this. They worked anyway, because someone had to. Several of them are now among the dead. There is a particular cruelty in the way Ebola treats the people who fight it. It spreads through bodily fluids, blood, vomit, sweat, which means the people most exposed are always the same people. The nurses, the doctors, the burial teams performing the traditional funeral rites that have been asked, gently and then firmly, to be changed, the mothers caring for sick children, the partners who stayed when everyone else stepped back. In Bunia in May 2026, the initial cluster that triggered the alert was healthcare workers. The people who identified the outbreak were its first victims. They went to work in a hospital without adequate protective equipment, without knowing what was moving through the ward, and they paid for that not knowing with their lives. This is not a story of failure. It is a story of what happens when a system is asked to carry more than it was built to hold. Think about the river the virus was named after. The Ebola River is still there, quiet and brown and indifferent, running through a forest that holds things we have not yet named, carrying in its ecosystem reservoirs of viruses that have coexisted with animals for thousands of years. When humans press into that forest, for logging, for mining, for survival, something occasionally crosses over. It finds a new host, it adapts to a new body, and then, if conditions are right, it moves. The conditions have been right 17 times in 50 years. In early May 2026, in a hospital ward in Bunia, a nurse felt a fever coming on. She had seen too much to ignore it. She reported it. She became a data point in an outbreak that would be declared a global emergency within 2 weeks. We do not know her name. The reports don't say. But she was there before the numbers started. She was the first signal in a system that almost missed her. And somewhere in Ituri province right now, as you watch this, as this script plays, the response teams are tracing contacts, building isolation units, negotiating trust with communities that have every reason to be afraid. The river keeps running. The forest keeps its secrets. And the virus, patient and precise, waits for the next gap in the wall.